I'm a hematologist and I specialize in disordered hemostasis and thrombosis, also known as bleeding and clotting disorders. And today I want to answer the question of how do you choose an initial therapeutic anticoagulant? How do you decide which one to choose? So I'm going to answer that question today. I'm going to say that it really does depend on whether the patient is inpatient or whether they're outpatient, because you're asking different questions. Now, when a patient presents with an acute blood clotting episode, usually they'll present to the primary care provider and be sent to urgent care, or they start out at urgent care, or they're seen directly in the emergency department. Okay, but they're presenting usually to an acute care setting, or if they're presenting to a non-acute care setting, they're being sent to an acute care setting. So for the most part, you are asking this question potentially of a patient who's going to be admitted in the hospital, that would be the inpatient setting, or if they're going to be sent back home. And sometimes we do that. Patients have a blood clotting episode, but they're otherwise okay to go home. Okay, let's talk first about the category of patients who are otherwise okay to go home. All right, there are many options for therapeutic anticoagulation today, which is super awesome. When I first started, there was warfarin and there was unfractionated heparin and fondaparinux. And now there are so many more agents, which are super awesome. I would say that there are three main things you should think about for the outpatient who's starting therapeutic anticoagulation. Number one, you should consider the reason for the thrombotic episode. Number two, you should consider their preferences. And number three, you should consider the ease of monitoring and patient education. And I put those two together because I do think that they easily go together. Let's start with talking about the reason for the blood clot. Okay, you don't always know why patients have blood clots, and sometimes we do thrombophilia testing that doesn't necessarily always tell us. However, what we do know are the circumstances usually under which the blood clotting event happened. And so if someone is in the outpatient setting, they had a blood clot, they could tell you if they were, if they had just maybe had a transatlantic flight, they were on a plane sedentary for about 12 hours. Or they can tell you that I just had major surgery a week ago, and then it fits. They have this clear provoking factor. But sometimes it's not clear, and you're not sure why they had the DVT or PE. If it's clear, or if they're in an oral contraceptive, you might say, oh, well, there's a clear reason why the thrombotic episode happened. Now, if the person has had a history of recurrent clot, and there's a question of whether it's antiphospholipid antibody syndrome, so they have a history of recurrent thromboses, they have lab abnormalities that are concerning for antiphospholipid antibody syndrome, or they have the history, if they're women of childbearing age, of recurrent miscarriages, those might be people in whom you think, oh, maybe this is antiphospholipid antibody syndrome. So those are patients in whom you might not want to start out with a direct oral anticoagulant. You might want to start out with warfarin. That brings me to the issue of education. So you might start out with warfarin, but for most patients, you're going to be okay starting out with a direct oral anticoagulant if they can tolerate food by mouth. So most patients are going to be fine with a direct oral anticoagulant, but it depends really on their kidney function, right? Do they have good kidney function? Do they not have good kidney function? Do they have good hepatic function? Do they have not good hepatic function? So those are some of the things you want to think about. First of all, where did this clot come from? Is there any possibility that this could be antiphospholipid antibody syndrome? And the question of what kind of synthetic liver or synthetic kidney function do they have? Because that will lead you to choose one anticoagulant over the other. Another thing you want to ask about is really the patient preference. And so the patient preference kind of does go along with anticoagulant monitoring. So, many of my older patients love to be on warfarin. They love to be on warfarin because, you know what, they get to come in and hang out with us and we're a fun bunch. And they can come to do that. And they like to be on warfarin because there's always someone checking in on them and saying, hey, how are you doing? How are you tolerating this agent? Many of our patients, though, especially now, as we get a lot of younger patients, they would prefer not to be bothered as much as possible. And so for many of these patients, a direct oral anticoagulant absolutely perfectly makes sense. How about the education piece? Okay, it's going to be really important that you educate patients on the risks of anticoagulants. And so, especially if patients are starting warfarin, you want to help with dietary counseling. You want to make sure you're in a setting where you have the time to answer those questions. And so education is really an important component of thinking about what type of anticoagulant the patient starts on. Another thing you want to think about is whether the patient can afford to pay for the drug or not. And that's something that sometimes a lot of us don't think about, but it is really important. And so it is important when you hand the patient the prescription to actually verify that the patient's going to be able to get the prescription. Because you know what? It's challenging to find out that you prescribed an anticoagulant for a patient, they couldn't afford it, and they didn't take it. And then they maybe come back to you 3 weeks later with a new blood clot. That's really important to consider the ability to get it as part of your factoring in your decision to start a therapeutic anticoagulant. Because sometimes people's insurance will say, well, you can get this one, but not that one. This one costs more money, but not that one. So those are things that you do want to help the patient sort out as well. Okay. Another thing you want to consider, though, is can the patient take medicine by mouth, or are they limited to medicines not by mouth? So parenteral agents, do they need a shot just by virtue of something that may be going on with their ability to absorb drug? So those are some of the things you think about. Okay. All right. That's for the outpatient setting. In the inpatient setting in general, if somebody's admitted with a major blood clot, they're usually going to start with a non-enteral, that's a parenteral, not through the mouth anticoagulant. And so that's anticoagulants really through the IV or subcutaneously. And that's a limited number of options. So through the IV, that would probably be unfractionated heparin, less likely a direct thrombin inhibitor, unless they have a history of heparin-induced thrombocytopenia. That might be one reason to be on a direct thrombin inhibitor. For the most part, for inpatients, it's unfractionated heparin. It's easy to turn off if there's any concern for bleeding. And most inpatients are going to start with unfractionated heparin. However, low molecular weight heparin is also an option as well, because it doesn't require the kind of monitoring that unfractionated heparin requires. However, for many patients, unfractionated heparin is usually the go-to. And then for inpatients, as they're transitioning towards the outpatient setting, then you start to think about all the other factors that we talked about earlier. All right, so it's kind of complicated. It's not so straightforward. What is the best anticoagulant to start with for a patient who's presenting with a DVT? Again, it depends on their underlying reason. One thing I didn't mention is that if the patient has an underlying cancer, an underlying malignancy, it may make you pause and think about which anticoagulant is best. If you had wanted to reach for warfarin, you may stop and say, well, is there a direct oral anticoagulant that would be beneficial to this patient at this time? You also want to ask the question, is the patient at risk for bleeding or not? And are there reversal agents for reversal of the anticoagulant? So many things that you think about. So it's not such a straightforward question, which anticoagulant do I start patients on? If you're going to err on the side of just like what's most likely, I think most patients who are otherwise fine will be able to start on a direct oral anticoagulant, but it's not always a given, and it depends on many factors. And so it is important to talk with your friendly neighborhood hematologist to answer the question as to which therapeutic anticoagulant the patient should be started on. All right, I hope that has helped demystify the process a little bit. There's so many more nuances to it, but I do want to keep this video short. Thank you for watching, and I look forward to talking again next time. Take care.